Great. Well, it's a great pleasure to have a chance to talk to you today. I want to thank the organizers for the opportunity to be here. And we're going to talk about the concept of precision epigenetic therapy for B-cell lymphomas. So this is my disclosures, and this is the summary of the talk. We'll introduce epigenetics, the Germinal Center reaction, and lymphomagenesis, the epigenetic basis of lymphomas, and then get to precision epigenetic therapy. So I think it's a useful paradigm to think of the genome and epigenome as the computer hardware and computer software paradigm. Just like computer software, the epigenetic programming in our cells is a series of software-like programs that can be written and erased as cells need to differentiate or respond to external stimuli and provide cells with a tremendous capacity to adapt to various environmental conditions. And it's thanks to the epigenome that our cells are able to adopt all the hundreds of different phenotypes and functions that they have. Even though every cell in our bodies has the same genome, the reason why they can behave in all these incredible ways is because they load different software programs onto their genome that confer these various phenotypes. All cell phenotypes are dependent on their software programming. It is the software programming or epigenome that determines every cell phenotype, including all tumors. And so if you want to know what the source code is for how these tumors behave, you need to go to the epigenome and see what's going on, and then you have your answer. The problem is that we don't really know very much about the epigenome. I would say that we're at the very early dawn of starting to know that it exists and beginning to understand what some of the components are. And components that you may have heard of include modifications of DNA, such as DNA methylation, DNA hydroxymethylation. You will also have heard of histone modifications, which are post-translational modifications of histone tails that are composed of many, many different covalent modifications. There are probably hundreds of these that occur in different patterns, and the patterning is critical. Also, non-coding RNAs are another component of the epigenome that bind to chromatin and help to organize where regulation happens. And finally, there is three-dimensional architecture also playing a critical role into how cells control gene expression. The 2 meters of DNA in the nucleus of every one of your cells is not randomly squeezed in like a bowl of spaghetti, but rather it's very carefully distributed into domains and organized perfectly so that it allows groups of genes to be in physical proximity to each other, talk to each other, and in this way be able to work in a coordinated fashion. Because genes can't talk to each other across long distances, they have to be close together, and that is how the genome organizes. So let's go to germinal centers. Everyone here is familiar with the germinal center reaction. You know this is the component of the humoral immune response that generates high-affinity antibodies and is composed of initially mature B cells lodged in secondary lymphoid tissues that in response to antigen stimulation migrate to the interior of lymphoid follicles and undergo somatic mutation and rapid proliferation in order to generate high-affinity immunoglobulins. And after going through rounds of division, they can interact with germinal center localized T follicular helper cells, follicular dendritic cells, and these interactions lead to selection of the few cells that manage to create a high-affinity antibody to ultimately become plasma cells that create high-affinity antibodies or memory B cells, whereas the vast, vast majority of these cells undergo cell death. Now, I should say that what's been of interest to us over many years is the unbelievable phenotypic changes that occur during the germinal center reaction. Cells really just become very, very different at each of the stages. And because all this is very rapid, it creates a very good scenario for exploring how the epigenome might encode for the different things that happen during these time frames. And this is further underlined by the fact that of the 150 highly recurrent mutations that occur in germinal center-derived in DLBCLs and FLs, that about 50 or 60% of all these mutations are in genes that encode for proteins that modify the epigenome or that direct the epigenome, i.e. transcription factors. And so this is the dominant theme, the most common class of mutated protein in all of these lymphoma subtypes. Among these genes are among the most common are those affecting KMT2D, also known as MLL2 or MLL4, CRIBP, AP300, EZH2, TET2, We'll talk about all of these in a minute. All of them are epigenetic modifiers, and they all play a critical role in the happy equilibrium between proteins that normally write epigenetic instructions or erase them. This equilibrium is critical. It confers plasticity and the ability of cells to change their epigenomes and undergo phenotypic transitions. If the balance between these writing and erasing forces is disrupted through any of these kinds of processes, mutations in these genes, then you're going to have things starting to get stuck. And that is essential to understanding how lymphomas occur. And these mutations, all of which are founder mutations that occur at the beginning or initiation of lymphomagenesis, play a critical role, and I'll show you some vignettes in a second on how this happens before we get to the therapeutic part. So interestingly, one of the major transitional points that's critical for the normal conduct of the germinal center is this interaction between T cells and B cells in the germinal center through a whole raft of receptors that are collectively known as the immune synapse. And mutations in these genes that we just talked about, all of them disrupt the normal signaling that occurs between B cells and T cells in a bidirectional manner that affects both cell types. All of this is linked to a transcription factor that all of you know called BCL6, which acts in coordination with these various epigenetic modifiers to set up the germinal center phenotype, and then needs to be overcome when B cells are exiting the germinal center reaction. So let's go through a couple of short vignettes. We'll talk first about somatic mutations that could be P and P300. These two proteins are histone acetyltransferases. They acetylate, that means activate the genome, and they especially function at elements that are called enhancers. Enhancers are intergenic non-coding regions or intronic non-coding regions that where the regulatory proteins assemble to control expression of genes. And CoREP is very, very important for, at this stage, enabling these enhancers to become activated that permit B cells to wind up exiting the germinal center reaction. But in lymphomas that lack CoREP or have mutations in CoREP, this simply doesn't happen. And what you have is persistent repression of enhancers that are normally turned off in the germinal center reaction by BCL6, which does this through its association with one specific histone acetylase inhibitor that's called one histone deacetylase called HDAC3. And so normally this is a happy equilibrium between HDAC3 and CoREP, but when you lose CoREP, you lose the equilibrium, and now everything gets aberrantly repressed, and these enhancers can't get turned on, and B cells are now stuck maintaining germinal center characteristics. They can't epigenetically rewrite their software properly. A similar thing happens with loss of TET2. TET2 is the only mutation in mature B-cell lymphomas that's known to occur at the level of the hematopoietic stem cell, so it truly is the most foundery of all founder mutations. And in the absence of TET2, a similar thing happens. TET2 is normally very important to create 5-hydroxymethylcytosine at the same sites where CoREP is supposed to be activating transcription, but in the absence of TET2, CoREP actually cannot function. So it's a very similar hit to losing CoREP. Once again, you lose the equilibrium between writers and erasers. The eraser HDAC3 is now dominating, and there is actually, aside from these enhancers getting stuck through HDAC3, there is a second effect, a second byproduct of TET2 that's also deleterious, involving aberrant gene promoter hypermethylation. So now you're hitting genes at two different parts of their anatomy, both at their enhancers and at their promoters. In the case of KMT2D, this is a protein that is a histone methyltransferase that introduces histone 3 lysine 4 monomethylation, which is required, again, for gene enhancers to respond to external cues from T cells. When you have loss of KMT2D, the system again gets stuck, enhancers get unable to get turned on. We think this is due to the actions of BCL6, again, but this time not in cooperation with HDAC3, but instead with a protein called LSD1, a histone demethylase, and possibly also with histone demethylases of the KDM5 family, still work in progress. And this leads to profound inability of B cells to respond to the critical CD40 signal that they must be able to detect in order to participate in the immune synapse. Finally, there are the gain-of-function mutations of EZH2, And EZH2 is a different story than all these past ones we talked about. All the mutations we talked about were loss of function mutations where you lose the epigenetic modifier. Here what you have is aberrant gain of function of the epigenetic modifier, which now becomes aberrantly active and able to carry out its function, which is to trimethylate histone 3 lysine 27 at gene promoters much more efficiently than it should. Now, one thing you should know is that EZH2 actually plays a critical role in the normal germinal center reaction, and in the absence of EZH2, there is in fact no germinal center. So it's an essential germinal center protein, and likewise, it's an essential protein for lymphomas that arise from the germinal center. But then there's the case of a subset of lymphomas that develop these mutations, where now this mark is put down very efficiently, and the usual erasers that are supposed to take this out just can't deal with this increased tilting towards the K27 trimethylated state. And what's interesting is that that repression, this mark doesn't actually do anything. It's just simply decorating chromatin. It's there to recruit other complexes that actually carry out that work, which occurs again in collaboration with BCL6. And then in lymphomas, you have this tilting towards the repressed configuration because the writer this time is enhanced. And you get, again, repression of immune synapse and disruption of immune surveillance. So the commonality of all these mutations is that their primary effect is an immune surveillance. That is how they function as tumor suppressors or oncogenes. They're not the classical p53-like, DNA damage checkpoint type of lesions. So now we get to the part about therapy. And let me first define to you what I think this means. So what is precision epigenetic therapy? This is treatments that hit a well-defined and specific target, right, which is important specificity, which we don't really have right now almost. The target is mainly an epigenetic modifier in the lymphoma context. Here's a MAC to PC error. The target drives a defined epigenetic dependency in non-Hodgkin lymphoma, so we must understand that there is actual biology that makes sense there. And patients can be selected based on biomarkers that indicate dependency on that particular mechanism. That is precision epigenetic therapy. That's what we have to aspire to because we don't have that right now, and we also are not very successful with these drugs. So let's go to examples. We'll talk first about CRIBBY-P. We've mentioned that CRIBBY-P loss of function leads to dominant effects of HDAC3. There are two approaches that are being investigated that I know of at least. One was recently published by the Della Favara group. They reasoned that if you lose CRIBBY-P, cells will become highly dependent on any remaining histone acetyltransferase activity. And they showed that if you now treat these lymphoma cells with drugs that target the other histone acetyltransferases, this leads to a toxic effect, which I think is interesting and may be a good way to treat these lymphomas. The approach that we have followed is targeting the opposing mechanism, HDAC3. We want the seesaw to become balanced again by hitting the opposing force, thus allowing genes to now, the remaining hats to take over, and then we have restoration of gene expression. So one of the most critical sets of target genes of CRIBBY-P that are lost in lymphomas are the MHC class II genes. And we observed that if you take primary human lymphomas and put them into mice and then treat with different doses of HDAC3 inhibitor, you see very strong dose-dependent activation of MHC class II, which the idea would be that would restore immune surveillance. Maybe you could use these drugs instead of immunotherapy to restore the immune system. You don't need to actually do things to the immune system beyond that, maybe. Or you could combine them. Here's another experiment testing this concept where human lymphomas are put into mice. The mice are then administered human T cells. The T cells are allowed to infiltrate the lymphomas. The tumor-infiltrating lymphocytes are then removed and put into culture with the same B cells that have been either exposed to HDAC3 inhibitors or vehicle, and then we measure the amount of killing. And you can see that these tumor-educated T cells will kill lymphomas that have been pre-exposed to HDAC3 inhibitors, and you can abrogate this effect by putting on MHC class II and class I blocking antibodies. So they're doing it through a class I and class II effect, which is likely because there's a heterologous, is probably a tissue histocompatibility effect, but it just shows you that the T cells can become reactivated. In a more syngeneic manner with a natural immune system, we used a mouse model driven by BCL6 and then treated mice with these lymphomas with either HDAC3 inhibitor, a PD-L1 checkpoint inhibitor, or combination. To show you a few examples of the data, you can see that both the HDAC3 inhibitor and PD-L1 inhibitor can create induction of serum interferon gamma, showing that T cells are becoming activated. The HDAC3 inhibitor is actually a little more efficient, but the combination is even stronger. And looking at CD8 cell infiltration to tumors shows you that both the checkpoint inhibitor and the HDAC3 inhibitor can do it, but the combination is, again, much more potent. So these compounds will be coming out for use in clinical trials next year. They're going through IND-enabling studies, and we intend to test this concept in patients to see if we can use precision epigenetic therapy as a form of immune reactivation with or without immune therapy approaches like checkpoint inhibitors. Now you'd say, okay, but we have HDAC inhibitors. Why do I care about by an HDAC3 inhibitor, since HDAC3 is one of the many HDACs that these drugs target? Well, here's a comparison of the drugs. When the pan HDAC inhibitors, HDACs carry out many functions in cells. There are thousands of proteins regulated by lysine acetylation. Much of this is perturbed by pan HDIs. There's no evidence that their effect on lymphomas is through an epigenetic mechanism. The gene expression profiles are bidirectional, and really there is not a single shred of evidence that they act through an epigenetic mechanism. They're very, very toxic to hematopoietic cells, other tissues. They cannot be given at doses that create full target engagement, so we can't even see how well they would work in people because they're too toxic. And also, they suppress the function of T effector cells, and so potentially antagonize any immune benefit. So really, this is not a precision approach for this. But HDAC3 inhibitors are better than this because HDAC3 has only been purified as part of a single complex, which is the one that we're targeting. Its effects by transcriptional profiling is almost entirely gene activation. There's no tox against hematopoietic stem cells, and it doesn't suppress T cell effector functions. So pan-HDAC inhibitors are not epigenetic therapy, and we should stop calling them that because they aren't, unless someone at some point generates some data to the contrary. To me, they are not. This is not epigenetic therapy. It's some kind of cytotoxic therapy up to now. EZH2 inhibitors are also of interest. You know all about them. They're in clinical trials. The idea is to block the hyperactive EZH2, restore balance to the force in that mechanism. The effect of EZH2 inhibitors are largely cytostatic. The main effect in lymphoma cells is to reduce proliferation and induce a partial differentiation state. Eventually, there is some cell death towards the end of this, but it's largely cytostatic. The effect of the mutations is more immunological than survival, and so it's probably more important at the level of gaining immune response. I'm not sure if you may be aware of a paper that came out from the Vancouver group showing that they just profiled their patients to see which mutations would correlate with low expression of class 1 and class 2, and found that when both of those are down, the most strongly correlated mutation with those is EZH2. And in fact, in the mouse models that we generated for EZH2 gain of function, we find the same thing where there is reduction in MHC class 1 expression, reduction in class 2, reduction in infiltration of CD4, CD8 cells as well. So EZH2 mutation creates cold immunological tumors, and this creates an opportunity as well for using epigenetic therapy against EZH2 to restore this. EZH2 inhibitors are interesting because they target both the oncogene effects of EZH2, but also those wild-type tumors that are EZH2 dependent. So it's not just for EZH2 mutant tumors. They're highly effective in the preclinical setting and are showing promising activity in patients. However, EZH2 mutation is not an appropriate biomarker to select patients for this therapy because many other patients will respond to. EZH2 mutation is linked to repression of antigen-presenting genes, consistent with suppression of immune surveillance. Although there is potential for combination with immunotherapy to be beneficial, several effector T cell sets are also EZH2 dependent, and this must be studied to understand exactly how to administer these drugs. My feeling is that most likely we'll need to do sequential treatments and study very carefully how T cells are affected. Very few people study the effect of potential drugs on T cells, and it's actually important to do that to get a sense of whether or not any kind of immune benefit will happen. It's also not clear yet what level of target engagement, which means suppression of EZH2, is required for maximal anti-lymphoma effect in different types of lymphoma, which is especially relevant for DLBCL. Currently, the greatest experience so far with these drugs is from the tazemetostat, which is given twice a day, and it's not known what level of target engagement this actually leads to and whether or not it's adequate for what kind of tumors. That has to be investigated. Okay, so in the case of TET2, it's a similar consideration. We know HDAC3 is counteracting it. We have published previously that HDAC3 inhibitors become very effective in TET2 loss-of-function lymphomas. And it's interesting to think also that perhaps combining these with drugs that are inhibiting methyltransferases might yield further efficacy, a topic that we're investigating that could lead to another form of precision therapy for those patients. And then there's finally the case of KMT2D, where we don't actually know exactly what to do. We have tested LSD1 inhibitors in lymphoma cells, and they have no effect at all, and that's because LSD1 has multiple effects beyond just histone demethylation. We've also tested KDM5 inhibitors, which may have some effect. This is our lab, also with Jude Fitzgibbon in the UK. These are two possible ways to go. We're also testing now LSD1 degrader molecules to see if that's a way to actually do this. So I'd say the jury is out on whether we have a way to yet target in a precision manner these lymphomas, but it requires more work. There are many other drugs out there of potential interest. The methyltransferase inhibitors do seem to be working well in DLBCL. There's a potential phase 3 trial that will be coming soon with CC46 in combination with mini-R-CHOP. And in the phase 2 trials, we're seeing promising efficacy in high-risk patients. There are no clinically relevant sirtuin inhibitors. Sirtuins are also lysine deacetylases. They also affect other histone modifications. We have some evidence from preclinical data with SIRT3 inhibitors being useful, but these are not yet really ready for prime time. BET inhibitors are the current fashion in epigenetics, but they are highly toxic and relatively pleiotropic in their action, so they're in a way kind of reminiscent of the pan-HDAC inhibitors. Their efficacy so far is not great, but there's evidence that in combination there may be ways to actually yield very synergistic effects, so I think it's still worth exploring these drugs. PRMT5 inhibitors, these inhibit histone arginine methylation, but they also inhibit arginine methylation of many proteins. I'm not sure they can really be called an epigenetic therapy, but they are here. They're in lymphoma clinical trials. PRMT5 is actually essential for the formation of germinal centers, and the drugs are very highly active in preclinical studies. So I think I'm not sure how they work in lymphomas, but they certainly are potentially active and worth watching how they do as they go through testing. So that's the story that I have to tell you today. This is our laboratory. Some of the work that I showed you about HDAC3 inhibitors was done by a former postdoc who's here in the audience, Patricia Mondello. And these are our collaborators who helped us with these various studies and our funding mechanisms. And I just want to let you know that we have this second translational research AACR meeting in lymphoma coming up in June, and hopefully all of you can attend. Thank you very much.